What I'd like to do now is to go to some of the questions from the other panel members. And Jack, Aiello, are you there?
I am, and it's nice to meet you, Doctor, over the phone.
Thank you.
I have some questions. I know that Dara was originally approved as a single agent and wonder if you envision it really being used as a single agent today, or instead should patients be trying to use it in conjunction with an IMiD and Dex, or get into a trial that does that?
I think I would encourage any patient to participate in a trial if possible. I don't see, except perhaps in very special situations like prolonged maintenance, or perhaps in the setting of high-risk smoldering myeloma. Outside of these areas, I don't see Daratumumab as a single-agent drug. I think for treatment of full-blown myeloma, we need combinations. But I do see Daratumumab as a part of the backbone therapy for multiple myeloma. So combinations would be the key to success, except for perhaps maintenance and high-risk smoldering myeloma, as I mentioned.
Are there actually maintenance trials there already looking at Dara as a single agent for maintenance?
That is planned and ongoing, yes.
Okay. And when Dara was tested as a single agent, I'm wondering, were there any prognostic factors that resulted in it being more or less effective, or did it work just as well if a patient had various high-risk factors?
Yes, we don't have many details on this, the usual prognostic factors, but my personal opinion is that using Daratumumab is more like hitting the target with a shotgun, because you have a drug that can attack the molecules on the surface. You're not trying to block a subtle pathway in the cancer cells. You're really hitting from the outside. So this is a major blow, I think, to the cancer cells. So it could very well overcome the usual drug resistance mechanisms. And this may explain why we see the response to single agent also in heavily pretreated patients that are resistant and had prior exposure to both proteasome inhibitors and IMiDs.
And finally, I once heard that it was not possible to design oral versions of monoclonal antibodies. Is that true, or could there be an oral version of Dara?
That's true. What is being done now to facilitate the use of Daratumumab in general practice is that subcutaneous versions of Daratumumab will be made available. So rather than giving it by the IV route, you'll be able to give it as a sub-Q infusion.
Okay. All right. Thank you very much. I'll turn it back over to Gary.
Thank you.
Thanks, Jack. Appreciate it. Cynthia Chmelewski, are you online?
Can you hear me?
Yes.
Yes.
Okay. Good morning, everybody. It's kind of early over here. I guess it's not as early over in Denmark. And thank you for taking your time to answer our questions. My questions have to deal with the first one about the infusion of Darzalex itself. I hear it's a very long first infusion, and I was wondering if you could tell us why it's so long, what types of pre-meds are needed with Darzalex, what are some of the possible infusion reactions. I know you talked about a few of them that we're seeing and how they could be managed. And I know I've heard concerns from local doctors' offices that are like on a 9-to-5 schedule, that what happens if they're infusing their patient and it's taking 14 hours and they don't have the staff there to help, would taking that first infusion as an inpatient be something to be considered? And that's it.
Okay, thank you very much. I would say that the first infusion is a long one to avoid the infusion-related reactions, more like 7 hours rather than 14 hours. So
okay.
I think with good planning and pre-medications in due time, you could manage within a usual working day. And after the first infusion, generally you can speed up the infusions to get it in within 4 to 6 hours. So I think it's not that difficult to see Daratumumab in an outpatient setting. That's actually what we are doing. Also with the ongoing clinical trials, we give it in an outpatient setting. But you need to plan carefully and start early in the morning. And the pre-medications, as you asked for, were antihistamines, paracetamol, and steroids. Pretty much like when we are using rituximab or other monoclonal antibodies, it's the same strategy. If we do during the infusion see reactions to it, which could be like shortness of breath or nasal congestion, we pause the infusion for like an hour, give more pre-medications, and we resume the infusion after an hour observation when the symptoms have subsided. And usually we can get done within a usual working day. And this, I should underscore that this is the first infusion that is problematic. The second infusion is much easier, and after from then on, from the third infusion and onwards, it's really running smoothly without problems.
Okay, good. I hear you're saying a lot about breathing problems maybe be associated with that first infusion. Is there special needs to be taken with people that have breathing disorders like asthma or COPD prior to the infusion?
Yes, that's a risk population where we need to pay special attention. I agree.
Okay. Also, I heard that Darzalex can interfere with blood typing for transfusions, and also about monitoring your IgG protein. Can you elaborate about why this happens, and if there's anything that patients should be doing prior to starting Darzalex?
That's two very important questions. There is a very weak expression of CD38 on red blood cells. So when you infuse Daratumumab, it will bind to the red blood cells without causing any harm. This is a very lucky situation. We were expecting that there could be problems out of this, but actually there's no signal from this binding, except that if you want to study the patient's blood type for comparison with a donor, in the case you want to give a blood transfusion, the blood bank could have problems interpreting their findings. So the advice to patients is that they have their blood typing done before they start treatment with Daratumumab, so that and have a card on them or have it registered in a computer, so the blood banks will know what was the blood type, is there any special needs for concern, and then you can proceed with blood transfusions without any problems. You just need to take care from the beginning before the first infusion with Daratumumab. The second question was that when you infuse Daratumumab, this is a monoclonal IgG kappa type protein, and when you have reached a plateau after some infusions, you will see this in many patients emerge as a very subtle M component of IgG kappa type. And if this is the same type as the patient had originally, it can be difficult to claim that the patient is in CR after treatment, because you will have this residual M component that actually is Daratumumab. But Janssen has devised a way out of this problem by removing the Daratumumab from the patient sample, so you can see what is daratumumab and what is residual M component of the patient's own.
Okay. So, and I guess if you're doing a bone marrow biopsy, you could tell the difference between the two?
Yes, from the beginning, when the patient is diagnosed, we will have a clear image, a clear picture of the patient's M component when it comes to type. Is it IgG or IgA, kappa or lambda? And we can follow it during treatment from time to time, take new samples and see if it disappears as it should with response to therapy. And then when we get down into very low levels of M component, which would be like 0.5 grams per liter, which is a very low level of M component, you will see this small peak of daratumumab that could potentially interfere with your interpretation if you don't use the method designed by Janssen, developed by Janssen.
Okay, good. Thank you. And our final question is, we're all excited about Darzalex, and we're wondering what types of trials are now enrolling, maybe using Darzalex as a combination therapy or in smoldering myeloma and the newly diagnosed. Can you give us an overview of what types of trials are out there?
We have a very important trial for the frontline therapy of non-transplant candidates with daratumumab in combination with lenalidomide and dexamethasone. That is, the patients are randomized, so everybody is getting lenalidomide and dexamethasone, and half of the patients are getting daratumumab on top of that. And I think after the French first trial, lenalidomide and dexamethasone is emerging as a backbone frontline therapy for elderly myeloma patients in Europe. And with the results from the randomized trial, I expect the combination of daratumumab, lenalidomide, and dexamethasone to be the new backbone for elderly myeloma patients. That's actually 2/3 of the myeloma population. When it comes to younger patients that are in Europe at least going for hydrotherapy and autologous stem cell transplantation, the good news are that daratumumab does not seem to interfere with stem cell collection. So you can safely use daratumumab in any combination upfront before you harvest the stem cells. Speaking about, as you asked, smoldering myeloma, I think you have to define the patient as having high-risk smoldering myeloma, because many patients with smoldering myeloma can have that disorder for many, many years without developing into a disease that needs treatment. But there are some signs where you can define a patient as having a high-risk smoldering myeloma, and those patients, I think, are treated on a trial with daratumumab of a single agent, and in some cases also in combination with lenalidomide and dexamethasone.
Okay, thank you so much for your very thoughtful answers.